And we're back. We have Jonas Thorlund. This is your first episode with us. So for people who aren't familiar, Jonas, can you give a little intro on yourself and where you currently live?
I certainly can, and thank you very much for the invitation. I'm located in Denmark, where I'm a professor of musculoskeletal health at the University of Southern Denmark. I'm leading a research unit, and I'm a co-lead of a center for muscle and joint health, which has about 50 researchers dedicated to research in musculoskeletal disorders. I think that was about that.
Perfect. Yeah, I found your name through reading some of your research papers, and some that you were the primary author and some that you were on the author group. And today we're going to talk about all things meniscus. So let's start out with just defining what is the meniscus, Jonas, and then what is kind of its value and purpose.
Yeah, well, basically the main function of the meniscus is to distribute load across the knee joint so that loading is actually absorbed in the areas that it is actually that are best accustomed to absorbing the load in the different parts of the knee joint. And this is also why having an injury to the meniscus is a really bad thing in terms of long-term knee health and osteoarthritis development. Actually, we've looked into this and did a systematic review on this, and we can say that if you sustain a meniscal injury, your risk of later onset of osteoarthritis is about 4 to 6-fold actually.
And we're going to dive into both degenerative and traumatic meniscal tears. Let's start with traumatic meniscus tears. What generally are the age group and demographics that present with a traumatic tear?
So traumatic tears are usually observed in the younger population. It's hard to give an exact age range. Obviously, if you're an older person and you have a healthy knee, you can also have a traumatic meniscal injury, but most of the tears are probably seen of traumatic tears are seen in patients who are aged 40 or younger. And having a traumatic tear is typically defined as a tear to a healthy meniscus. And it's typically sustained, it can be during a work incident or a sports-related trauma. That would be the typical thing. On the other hand, if I may, I can continue with the degenerative meniscal tears. These tears are typically seen in middle-aged and older persons, so that would be 40, 45 or older typically. And these tears, these are tears where patients typically have symptoms that develop over time. And if you look at the meniscus, it's quite clear that these types of tears are actually tears to an already degenerated meniscus. So most often people won't remember that they had a specific incident. That might be, but it might also be minor incidents that wouldn't cause a tear to a healthy meniscus, but because your meniscus is already degenerated and the tissue is softer, things that wouldn't normally cause a tear in a degenerated meniscus.
And this answer may be similar to both, but if a clinician is having a patient present to the clinic and there's no diagnosis yet, and they're trying to rule out other pathology, other tissues that are injured, what should clinicians be aware of when trying to rule in or rule out a traumatic meniscal tear? And then on the other hand, a symptomatic degenerative tear?
So that's a really good question. And it's actually a question that can be a little bit hard to answer. Mostly guidelines, they recommend that if you are to diagnose meniscal tears, this is a diagnosis that is based on the patient's history. Often you also use some clinical tests. And then you obviously also you talk to the patient how the symptoms started and what types of symptoms that they have. And in the younger population, you more often also do an MRI to confirm your suspicion. The thing is that the clinical tests that we need or that is used to diagnose meniscal tears, they are actually they are quite good at capturing most patients who have a meniscal tear. However, the downside is that many of those who have a positive test actually turn out not to have a meniscal tear anyway. And this is because the symptoms that are kind of provoked with these tests are also symptoms that are common in other types of knee injuries. So often with younger patients, you would have an MRI, and these patients obviously they also often have contusions, or it could be that they have cartilage damage instead of the tear, but it could also be alongside the tear. And then importantly, also you want to know if they actually have an anterior cruciate ligament injury, an ACL injury. Because this is important for how you manage the patient. And we know that many, or at least a large proportion of the traumatic meniscal tears, they actually occur in people who also have an ACL injury. So, but this is a different patient group. This is typically patients that we would call ACL patients and not meniscal tear patients. So I think that when we're talking about patients today with meniscal tears, that's where we kind of think of that as the main injury to the knee.
And yeah, let's go into degenerative with, as you said, the middle-aged to older populations. There's other considerations. What are we trying to rule out there?
So I would say for most patients with degenerative meniscal tears, they often have cartilage damage or other types of degeneration inside the knee. And to me, and I know this is something that has been debated a lot, and there's quite a lot of evidence to suggest that that's how it is. Having a degenerative tear is likely osteoarthritis showing in the meniscus. So we actually tend to think about patients with degenerative meniscal tears as patients with osteoarthritis. And then depending on the state of the rest of the knee joint, if they have if they have a lot of other pathology, it would be a clear case of osteoarthritis knee with a degenerative meniscal tear. But in the other case, I would actually consider having a degenerative meniscal tear, even if you have no other pathology. This is probably where you, for some reason, see the first signs of osteoarthritis in that knee. And I would I would actually think that for most patients who are older, where you suspect a meniscal tear, I don't think that you necessarily need to do an MRI. I would actually discourage it, because there is this kind of logic that when you have some sort of symptoms, you see a tear on MRI, then it suddenly becomes a symptomatic meniscal tear. But you have no idea if the symptoms are actually from the meniscus or if it's from other tissues in the knee joint that also have beginning osteoarthritis. So, but that often becomes kind of an argument to do surgery to a degenerative meniscus, which we will discuss later what is the appropriate treatment. So we'll come back to that.
Before we go into these management options, you alluded to the traumatic tears, especially in the younger athletes or younger populations, to receive imaging to also see if there's concomitant injuries and if there's a true meniscal tear. Is that the recommendation immediately when a patient presents to the clinic, or is there value to waiting a few weeks to just see how the symptoms and the trend of function and symptoms improve? What's the recommendation there?
So I think it depends on where you read. There are different types of recommendations from different societies, but in my opinion, a lot of the management that you would do with the patient would be quite similar in the starting phase, no matter what type of knee injury they have. And if you have a patient with a meniscal tear where you start, perhaps you start with exercise therapy, and obviously you wait till they can actually move their knee again, and then they have some range of motion in their knee. Perhaps they have a contusion or something that needs to settle down. Then if the patient gets better after that, well, then I guess that's fine. And if not, then you would probably spend more time on a specific diagnosis.
And you had mentioned generally what to, how to think about this being potentially a meniscal tear, but based on a patient's examination or on their subjective history of the mechanism of injury, what are you cluing in on to think or to identify as these are more mechanisms that would lead towards a potential meniscal tear, or what they're describing as their limitations, their current kind of signs and symptoms? What should clinicians be thinking about when it comes to meniscal tears?
I think that's actually quite hard to say. We've done a few studies looking into what are the types of symptoms that patients with meniscal injuries most commonly report. And if you look at those types of symptoms, it's typically it's difficulty with squatting. They have pain when they walk on stairs. They feel limitations in doing more strenuous activities. There can be sometimes there are also some clicking sounds or other things that they can hear from their knee. And when I say it, it sounds very specific to a meniscal tear. However, these symptoms are actually also very common in patients who have other types of knee injuries. So I think that's also why the recommendations they are that you should look at the overall picture from the history of the patient. How did it feel? You should look at the clinical test, even though that we know that they are not very specific. And then you you get that overall picture from all the information that you have. And then I guess, especially for the younger patients, if you are then still in doubt, well, then you can consider referring that patient to an MRI, if you think that has if that would change a lot for how you would manage the patient, I would say.
And I believe you were on one of the papers discussing the assumption that if there's mechanical symptoms, people always lean towards a meniscal pathology, but that's not necessarily the case. Can you elaborate on that just a little bit?
Yeah, so we had a large cohort of patients with meniscal tears, about 650 patients. But when we recruited them, there was also a large group of patients which turned out not to have a meniscal tear. But we didn't know that at the beginning, so we asked them a lot of questions at baseline on how they the amount of mechanical symptoms they had. So this was symptoms of catching and locking. It's patient reported, so it's not necessarily so that you have a patient who cannot move their knee. That's most likely not the case. That's actually quite rare. But if you ask the patient, do you feel that the knee kind of catches or occasionally locks? It actually turned out that those who at the surgery turned out not to have a meniscal tear, that symptom was at least as likely to be present with them, actually a little bit more likely than in those with a meniscal tear. And that's why we kind of say that. So having mechanical symptoms, it's definitely something that patients with meniscal tears have, but you cannot just rule out everything else because of that, because a lot of other patients with other types of knee injuries, they report the same types of symptoms.
Let's dive into these first line management options. Again, we'll start at traumatic meniscal tears. What does the evidence suggest for a patient presenting with a traumatic tear?
So until actually quite recently, I think that there was really no studies who had looked at or at least compared a surgical to a non-surgical option. So in 2022, our group, we did a study which was led by Professor Søren Skov, and I was the senior investigator on that study. And at the same time, in the same year, there came out a study from the Netherlands, the STAR trial. Our trial was called the DREAM trial. And before that, I think that it was considered that at least in many places, that surgery was kind of the gold standard treatment for traumatic meniscal tears. It can differ a little bit, but at least there was no evidence to kind of suggest what would be the better. So we actually did this trial where we randomized patients with young patients. They did not all have traumatic meniscal tears, but they were all between 18 and 40. They were randomized to a strategy of either early meniscal surgery, which was repair or resection at the discretion of the surgeon, or those who did not receive surgery, they received exercise therapy and patient education for 12 weeks, with the option of later surgery if they felt that was needed at a later time point. And in the study, we found at 12 months that early surgery was not superior to exercise therapy and patient education. About 1/4, 25% of patients who were randomized to the non-surgical arm to exercise, they opted to have surgery later in the trial, so between 3 and 12 months in the trial. So one way to interpret this is that if young patients with meniscal tears start with exercise, only 25% of those would actually later go on to having surgery. The nice thing was that then there was this Dutch trial, which was conducted at the same time. It came out 4 months after our trial, published 4 months later. In that study, they exclusively included patients with traumatic meniscal tears, young patients under 45 with traumatic meniscal tears, and they had the same design, early surgery or exercise with the option of later surgery. And in that study, they found exactly the same. Surgery was not better than exercise therapy. They had a little bit larger crossover. I can't remember exactly. I think it was about 35% of patients, but they were all traumatic in that group. So I think that based on that, in the coming years, I hope there will be more trials, but at least we had 2 trials coming out at the same time that basically showed the same. There was a little bit of a difference in the design and a little bit of difference in the study populations. But overall, I would say that the good thing about the trial was that both groups, those who had surgery and those who had exercise, they actually improved. So we cannot say which is better of the two. So that means that patients actually have 2 options to choose from. You might have a preference for surgery. Well, then it seems that you will do just as well with that as with exercise therapy. But you can also start with exercise, and if that works, well, then for a large proportion, it seems that the surgery won't be necessary. But again, that's up to the preferences of values of the patient, and then discussion with the clinician, I think.
And both of those studies were just looking at isolated meniscal tears. There wasn't any concomitant pathology.
So when you say that specific, I would say no. There is, when you look inside the knee of those patients, it's very rare that you only have a meniscal tear. There will always be a little bit of damage to other structures inside the knee, but that's not the main thing. They didn't have ACL tears or PCL tears or other ligament tears. They didn't have other pathology that kind of required surgery in none of the trials. The meniscal tear was the main thing, but there could be all other minor stuff. Some also had some small bone marrow lesions and stuff. We can see that on the MRIs when we've looked at them afterwards.
For those in your group, that 25% that elected for surgery later on, and then the other research group, about 30, 35, you said, was there a deeper dive into why those individuals ended up opting in for surgery? And was there a larger group that had a certain type of meniscal tear, whether it was a buccal handle or longitudinal? Was there any correlation with people that did get the surgery with a specific type of meniscal tear?
I think the most common reason, if I recall it, it's in the supplement of the main study. If I recall it, the main reason in our trial, in the DREAM trial, for opting for surgery was that people felt that they had persistent symptoms and felt that they they didn't get what they expected from the exercise therapy, so they thought that they would gain more from having the surgery. We haven't looked specifically into if there was a specific pattern with the tears. It's when you dive into these very small groups, it's only actually 16 people, then the numbers are very low. So it's very hard to actually say something. You might pick up a small signal for something, but it might be quite random actually. So we've actually not looked into that for that reason. What I can say from both our trial and the STAR trial was that those who opted to have surgery at a later time point, in our study, in the DREAM trial, the primary endpoint was at 12 months. Those who opted to have later surgery, they actually ended up exactly the same place as the other patients at 12 months. So it didn't seem like if you didn't have surgery from the beginning that you kind of missed out. You catched up with the others at 12 months. So that it wasn't kind of a bad thing in the long run. Perhaps you could expect that they would do worse in the long run or something, but they actually catched up to the others. And it was exactly the same thing that was seen in the Dutch and the STAR trial. They had their primary endpoint in 2 years, and at 2 years they were all the same, those who opted for later surgery also.
And they were all the same in what aspect? Their kind of self-report level of function, or what were you all looking at there?
So this was the primary outcomes in both of the trials were patient-reported outcomes. In our trial, we used 4 of the 5 subscales in the knee injury and osteoarthritis outcome score, also known as the KOOS. So that was pain, symptoms, activities during more strenuous things, and quality of life. And the Dutch trial, they used, as far as I remember, it was the IKDC score, which is a different knee score. The questions are very similar to the KOOS. If you look at all the knee scores, questions are asked a little bit differently, but they are very much the same. So these would be many of the same aspects that were asked about here. So very kind of a broad array of questions about function, pain, symptoms, and quality of life.
So kind of a summary on the current landscape of the literature, and when a clinician's trying to interpret this and discuss this with patients with this specific group, that we can be optimistic or hopeful that a lot of people with traumatic meniscal tears will be able to recover and return back to their end goal without needing surgery. There is this 25 to 35% population that will end up opting for, and let's start with non-operative management and see how your symptoms trend. Is there, if the patient or their parents ask, well, how long should I wait for conservative management or exercise-based therapy before determining whether or not I get surgery? There's probably a ton of uncertainty there, but does your group, or do you have any recommendations on how long should you trial non-operative management?
So, I can't say for certain, and I don't have any real, data because we haven't tested that. But what we did in our trial was that we had an intervention that was 12 weeks, so 3 months. So we basically we put in a lot of effort for people to actually go through those 12 weeks before opting for surgery. And I actually don't think that we had any who opted for surgery before actually giving it a real go. And I think that is probably a good thing to suggest, that you should at least try it for 8 to 12 weeks. If you really haven't moved anything within the first 8 weeks, it's very rare that something then suddenly happens after week 9 or 10 if something hasn't really happened within the first 8 weeks. But I would say that you should at least give it 8 to 12 weeks before you opt for something else, unless of course there is a specific reason for that you have other things,
And then educating them on the comparison of, regardless of your decision, what our current understanding is at about the 1 year or 2 year mark, individuals in the surgery versus non-surgical group are kind of in a similar spot. So that's another piece of education to provide.
That's at least what our data say. What we have to remember that when we present data from trials, it's always the average, and there is quite some variation between patients. Obviously, there are those who do super well. There are those who kind of do average, what you see in the trial, and then there are always also a few patients who really don't benefit from anything.
Yeah, that's fair enough. There's a bell curve, and yeah, there's a lot of individual differences. Let's go ahead.
I was just going to say that the improvements that we see on average, both after the surgery and after the exercise, they're actually it's pretty large improvements. But one thing that you also need to think about is that it's actually very few patients who will feel that they have a healthy knee again. So I think that's probably also something to discuss with patients, that if you have a serious knee injury, a meniscal injury, it could also be an ACL injury, that we can do a lot to help. They can improve a lot, but it's actually very few patients who will experience that they have a completely healthy knee again. I think that's actually, so you don't go seeking for the last part that you will probably never gain. At least when we see in our data, it's very, very few that gets really to the top again.
We just had a recent episode discussing the reality of re-tear rates in ACL populations and relatively high numbers of re-tears. Is there data on these primary meniscal injuries? What are the likelihood or the odds of re-injuring that meniscus or the other meniscus after that first injury?
I'm not sure I can say that, because it could be a different place in the structure, whereas when you have the ACL, it's either torn or it's not, and then if you then re-tear it, it's the same thing that's torn. But for you have the instance where you do repair. In young patients, you also when you do the surgery, you can either do a resection or a repair. And when you do the repair, the idea is that you kind of save the meniscus, so that hopefully it will, when you fixed it again, you often sutured, that it will heal, and that it will be a functional meniscus again, in terms of, and that will help you in the long run in terms of avoiding you getting osteoarthritis. However, we know that actually quite I would say, relatively large proportion of those who get their meniscus sutured, they are actually that doesn't really, they're retorn, and you have to have a surgery again. It's you can see very different numbers. I would say that on average, it would probably be something between 15 and 25% of patients who have a repair where it doesn't really hold, and you need to do something again. And that's also something to consider if you get a repair, that you have a relatively large chance that it will not hold.
Let's transition to first-line management options for these degenerative tears. As you mentioned earlier, there's maybe a transition towards the narrative or towards the reality of this is more of a potential symptomatic osteoarthritis presentation, or this is the bigger kind of culprit in a sense. What are the management options for these middle to older age adults that are experiencing these degenerative tears and likely symptomatic OA?
So if we look at what the evidence says, that there has been at least 10 randomized trials that was published between 2002 and 2018 with the middle-aged population with degenerative meniscal tears. And these patients have been in the continuum of having a degenerative meniscal tear and no radiographic osteoarthritis signs, to patients with degenerative meniscal tears and moderate to severe osteoarthritis on x-rays. That's kind of the population that have been in these studies. And if you look at the age of those patients, they've been between 40 and 70, those who were in those 10 trials. And systematic reviews of these show that arthroscopic partial meniscectomy, which would be the surgical option here, no repair, but only resection. It shows that the systematic review shows that arthroscopic partial meniscectomy has no better effect than placebo surgery or exercise for patient-reported outcomes. So based on these reviews, there's been a lot of guideline work in the last 5 to 10 years from different interest groups and associations that have been issued. And these, they differ a little. Either they recommend completely against surgery for degenerative meniscal tears, and others, they recommend that you start with exercise and only offer surgery to select populations if they don't get symptom relief from the exercises. So that's kind of the continuum. It depends on a little bit on which type of associations have issued the guidelines. And from my perspective, as I also alluded to before, if you consider this and kind of an osteoarthritis population, and this is the degenerative tears, just manifestation of osteoarthritis in one tissue, the meniscus, and there is likely also osteoarthritis in other tissues in the knee joint, that then might explain why surgery hasn't been super effective, because you have probably done intervention on one part of the knee and the symptoms could stem from likely also other parts of the knees. So for those patients, I would basically recommend that you follow the guidelines for treating patients with knee osteoarthritis.
Yeah, that was my understanding. We at E3 were going to put out a blog and YouTube video on non-operative management options for knee OA. And that's what I found in the literature, that a lot of reviews and guidelines were recommending against a partial meniscectomy. And if non-surgical management and a lot of other kind of health factors are addressed or trialed and there's not an improvement and symptoms are limited enough, then it's a consideration for a partial or total knee replacement for these knee osteoarthritis conditions. Let's dive into meniscectomies and meniscus repairs for the traumatic meniscal tear. As you mentioned in your group, the DREAM trial, it was up to the discretion of the surgeon as to what was going to be performed when they were in there. Can you touch on just the difference between what is a meniscectomy and what is a meniscus repair? And we'll start there.
Yeah, sure. So repair is typically chosen if there is the possibility to suture and if there is a healing potential of the meniscus. So that means that the meniscal tear has to be in the part of the meniscus where there is blood supply. So you often call that the red zone. Some would also do a repair in the red-white zone, but basically no one would do it in the white zone. And the main reason for doing the repair is to kind of save the meniscus and save as much tissue as possible, and hopefully create a meniscus that's completely functional again to avoid later osteoarthritis development. Oftentimes, actually most often, it's not possible to do a repair, and then you will do a resection where you remove the damaged parts of the meniscus till you have what's called a stable rim, so that you don't have all kinds of things sticking out of the meniscus. That's kind of shaved nicely round and flat. And that's basically the two options that you have. Then there is a lot of more experimental work going on doing meniscal transplants and other types of surgeries, other types of repairs. And I'm not an expert in that. Then I think you should have an orthopedic surgeon on your podcast if you want to know more about that. But my understanding is that is still considered as a kind of experimental treatment. It's not mainstream treatment. So, but you have the repair with the sutures and other kinds of ways to fixate the meniscus. As I said before, the downside of the repair is that you often perhaps have to be a little bit more careful in the beginning with the rehabilitation, so that you don't rupture or tear the sutures. And then, even though that you're careful, about 20% of the sutures, they either you tear them or they won't work for other reasons. So that there is quite a re-surgery rate on that, because then you would most often shift to do a resection instead. So that you start with a repair and then you get a resection instead. So, but at an additional surgery. We have looked a little bit into, because one of the things that is actually lacking and we are a little bit interested in and considering is what is actually best for the patients. Is it the repair or is it the meniscectomy? I completely follow the logic that doing the repair, if possible, would be the best thing to do in terms of avoiding osteoarthritis, but we actually don't have any data to support it. We don't have a trial that has. We have done some observational studies. We had this larger cohort, which I talked about before, knee arthroscopy cohort, Southern Denmark, 650 patients who had meniscal surgery. It was, and among those, there were also patients who had meniscectomy and some who had repair. And we've actually compared those two patient groups. The thing is that it's not randomized. This means that there is what you call confounding by indication. There is a reason some get a repair and there's a reason that others get the resection. So it's not the same types of patients, but what we can see is that on average, those who get a repair, they actually have a little less improvement in patient-reported outcomes compared to those who get the resection. But that is also because a proportion of those, about 20%, had resurgery. So there is this kind of trade-off. So I think it's not a complete no-brainer if you should choose one option or the other. Thinking about if you're an elite athlete that wants to get back quickly, if you then get a repair, and there are different things that comes into play. I think we need some more data on that, actually, too, at least in my opinion.
Is it more common for what you'd mentioned in your trial, the surgeon to not have an answer prior to going in and starting the surgery as to whether or not a meniscectomy or meniscal repair, or are there still a good amount of patients that already know going into it that they're going to get a repair or a meniscectomy?
Based on the MRI, it's often possible for the surgeons to kind of talk to the patient about. So we think that we see this and this type of tear, for instance, a bucket handle tear, and we think that we'll be able to suture it. And if we are, we will do that. Otherwise, we'll do the resection. So I think it's possible to have an idea about what you're going to do, but MRIs are not 100% certain. It can be different when you go inside the knee joint, and then you will need to alter your strategy. But I think that most surgeons would probably talk to the patient about what they would expect to find and what option that they would use as the first option, and then say, okay, and if that's not possible, then we'll do the other thing.
And then for these active populations or these athletes wanting to get back to sport, what should the education be from the surgeon and or the physio on if you do were going to receive the meniscal repair, what does that potential timeline look like versus a meniscectomy?
I think again, it's hard to. I'm not familiar with so many studies who have compared that. I know that there's been a Danish study some years ago that was looking more into how aggressive you could be with the rehabilitation, and it turned out that you could be a little bit more aggressive with the rehabilitation than what was considered at that time. But I'm not entirely sure with the time frame how much it would differ. Um, but there is obviously this thing that you need to be a little bit more careful in the beginning, and then even though that you're careful, you can re-tear or you can tear the suture, so that you need to go back from scratch again. On the other hand, from kind of a knee health perspective, I would obviously always recommend that you. I think it's sensible to do the repair if possible. I think that's very reasonable. But from a kind of being a researcher, you really like to know and have data on that before you really recommend something. So I think more data is really needed on that to give really a trial is needed.
Is there any other recommendations or options that patients may consider or that should be brought up outside of the exercise focused non-operative management for these traumatic tears and or the surgery? Is there anything else from a injection perspective, anything that is really not recommended or that is potentially a short-term symptom relief? What are things that patients are commonly considering or asking?
Well, I guess that with as with many other types of traumatic injuries, that if you're in a lot of pain, that there could be that you take some paracetamol or acetaminophen, and maybe NSAIDs, either as oral NSAIDs or as cream, that you apply. That would be reasonable, I think. But in terms of injections and stuff like that, I don't really think that's something that there's really any good evidence that should help for a meniscal tear.
Is there anything else that you feel like we didn't touch on from the management options or things that physios and rehab providers should be aware of from either the traumatic meniscal tear perspective or from these symptomatic, degenerative, or knee-OA presentation groups?
I guess when having been involved in this field for quite a long time, I think that the major difference now compared to perhaps 10 years ago is that the role of non-surgical treatment, in particular, when I say non-surgical treatment, I say exercise for meniscal tears, that has changed a lot, and it's a lot more accepted, and also from the surgical community. As I said, our trials for the young patients, it doesn't show that surgery or exercise is better than the other. So you have two treatment options. For the middle-aged and older patient group, I also think that it's quite clear that exercise is at least the first choice, and many people, also surgeons, would not really consider surgery for this for the degenerative patient group. There should be a very, very specific reason for that. So I think that has changed quite a lot over the past 10, 15 years, the entire narrative and the role of exercise as a treatment option for these patients.
For some conditions, there's more of a broad recommendation for varying types of exercise, and there's a lot more freedom of just the general health benefits and how that systemic impact can help kind of these local presentations like knee-OA. From a meniscal tear perspective, either in y'all's group or in general, what do you is there a more specific recommendation on this is the type of exercise that it should be performed, or how should clinicians think about, recommending exercise? How specific do they need to get?
So that's actually quite an interesting question. And, when the two trials that there are on the younger patients, on those under 40 mainly with traumatic tears. So in our study, the DREAM trial, we had quite a supervised program. 2 times a week. Sessions were actually about 60, maybe 75 minutes long. It was a combination of neuromuscular exercises focusing on gaining knee control and these kind of things, but there was also a kind of a heavy resistance training component to that because it's a young population. So it was quite supervised, very specific exercises. We had progressions in the neuromuscular exercises. There was strong focus on, following guidelines for progression, for resistance training, these kind of things. Whereas in the Dutch study, the STAR trial, that was a kind of a more pragmatic setup that they had. So they patients who were randomized to exercise therapy, they were referred to a physiotherapist, and then they had some general guidelines about what to do with the patients. So, but that must have varied at least much more than in our trial. And when you look at the results and the improvements in the exercise groups in the two trials, it's actually quite similar. So, something inside me want to say that it's very important, that it's very specific, and it's these and these exercises that we chose. But I guess I think when you look at the data, I cannot really say that. And so from that, it seems that if you go, obviously the physios who were in the trial, they were trained physios. They were used to having patients with knee injuries, so they knew that what they were doing. But it has varied quite a lot on that trial, and they got more or less the same results as we did. We had a little fewer crossovers, and that might be because they had more, they engaged more with the physios in our study because of the supervision. But in terms of how much they improved in patient-reported outcomes, it's very similar.
And what should the narrative or education piece be for athletes or patients receiving exercise and non-operative care? What should the physio describe as what's going on? Are they healing the meniscal tissue? Are they making the other surrounding tissue stronger? If patients were to ask, what's the purpose here and how is this helping my damaged meniscus? What are your recommendations on what we should say?
I think that's actually a little bit tough to say because people will react to different things. I think that you should probably not tell them that when you do exercises, you fix the meniscus, because I don't think that we have any reason to believe that that's what we're doing. I think what we are doing is that we are treating the symptoms that they have. They had an injury. They have been immobile for perhaps a period of time. They need to regain their strength. They need to regain the trust in their knee, I would say. That's quite important. And then the damage that they have in the meniscus, it will probably still be there. But again, how much of the pain is actually from the meniscus? That's a little bit unclear. That there's not many nerve fibers in the meniscus actually, especially in the white zone. There's really no nerves. So I would probably say that if you have some sort of tear, it will kind of it will dissolve. Your meniscus is not healed, but if you have some sort of tissue that's floating around, that will dissolve over time. And it's hard to say what actually happens to the meniscus.
Yeah, I was hoping that was going to be your answer. And it does get tough as a clinician because patients can fixate on the MRI report or potentially what the surgeon told them and almost scaring them into surgery and trying to be optimistic that, either this, like you said, can dissolve or there can be this kind of resolution over time to this damaged meniscus, and exercise isn't doing that. It's time itself and the body's natural healing. And or if there's continued damage to the meniscus, you can still return from a functional perspective. You can have improved symptoms, and this damage doesn't result in you ultimately always needing surgery or always being in a place where you can't return back to what you want to. Is that fair enough to say?
Mm. Yeah, and yeah, I think that's quite fair.
Anything else you want to touch on, Jonas, before we wrap it up? I think we went through pretty much everything that I was hoping we could talk about.
No, I think I'm good.
Yeah, well, I appreciate you coming on, and I think this helps provide perspective and awareness of the current landscape of meniscal tears and putting it into perspective of these younger, more athletic populations, and then these older, middle-aged adults, and how we should think about these a little bit differently, and then what are some of the similarities. We'll call it there. This was great. We'll link some of your research in the show notes and where people can hear and learn more from you. Thank you so much, Jonas.
You're very welcome. Thanks for having me.